Good morning. The topic for today's seminar is Biomechanics of Edentulous State. It will be covered under the following contents. With an increasingly elderly population worldwide, the edentulous group of patients has been continuously expanding, result in the significant raised needs for prosthodontic treatment. Coming to definitions, according to GPT-9, biomechanics is the application of mechanical laws to living structures, specifically the locomotive system of the body, or the study of biology from a functional viewpoint. The prevalence of edentulism can be varies greatly worldwide, and the causes of edentulism being dental or non-dental. Dental being caries, periodontal diseases, development, cyst tumors, and non-dental being the level of education, the behavior, and the attitude towards one's oral health and occupational and financial status of the patient. The clinical implications of the edentulous stomachognathic system are divided under modifications in area of support, function and parafunctional considerations, changes in the morphological face, height, and DMG, cosmetic changes and adaptive responses. Coming to modifications in area of support, in the dentulous state, the periodontium attaches the tooth to the bone of the jaw, providing a resilient suspensory apparatus. Resistance to functional forces. It is comprised of the hard and the soft tissue, that is the PDL and the lamina propria, and the hard cementum and bone. The PDL along with the lamina propria maintains continuity between the hard tissue components, providing the means by which the forces exerted on tooth are transmitted to bone. It provides support, positional adjustment of the tooth, and sensory perception, which the edentulous patient is deprived of. The dentures are supported by the mucosa, submucosa, periosteum, and underlying bone. Periodontium as a supporting element, the PDL and the gingiva are highly organized and oriented. They are also highly vascularized, innervated, and contain elastic fibers and are approximately having uniform thickness. Coming to cementum, rarely resorbs, and the bone is very well vascularized. Normally, the bone receives tensile loads and it provides an excellent medium for PDL attachment. Support mechanism for the complete denture is made up of the bone and covering mucosa. The mucosa, which is stratified squamous epithelium, is highly keratinized. There is a variability of the thickness and the contents of the submucosa, as well as variation in the keratinization. Therefore, there is uneven attachment and keratinization. There is diminished proprioceptive nerve ending and reduced elasticity. Age plays an important role in the ability of the oral mucosa to recover from compression. Residual ridges. The loss of teeth and periodontal support results in the removal of an important sensory mechanism, and there is a change in the loading pattern of the alveolar bone from tensile to compressive, with forces being predominantly vertical as well as horizontal. Now, the osseous structure not only supports the denture, but has direct bearing effect on the impression-making procedures, position, and contours of the finished denture bases. The primary stress-bearing areas generally have a thicker mucosa or underlying bone that is less subject to resorption because it is cortical bone. And a secondary stress-bearing area is made up of cancellous bone and is subject to resorption remodeling after dental extraction with long-term denture wear. The mucosal support, the mucosa, the PDL support in the dentulous state is 45 centimeters square in each arch. It has viscoelastic properties, sophisticated sensory mechanism, and the potential for the bone remodeling to cope up with diverse direction, magnitude, and frequency of occlusal loading. And the area of mucosal support in the edentulous state is in the maxilla. It covers 22.96 centimeters square, and the mandible is approximately 12.25 centimeters square. The mucosa itself demonstrates little tolerance or adaptability to denture wearing, and this disadvantage can be worsened by presence of any systemic disease. Coming to support areas of the maxilla, the primary stress-bearing areas are the horizontal portions of the hard palate lateral to the midplan and are the flat areas of the palate. The epithelium here is keratinized and the cortical bone is present. The anterolaterally, Submucosa contains of adipose tissue and posterolaterally it contains minor salivary glands. The resilient layer acts as a cushion. The anterior half is made of the rugae, which has dense connective tissues. Here the forces are oblique. Coming to crest of the ridge, secondary stress-bearing area, cancellous bone is seen. So it is, and the periosteum is firmly attached. Coming to the mandible, the buccal shelf area is the area of primary support where cortical bone is present and the presence of the buccinator fibers which are attached anterior posteriorly makes the bone barely resorb. And ideal for a primary stress-bearing area is the upward slope resistant displacement of the denture. The retromolar pad, it lacks the long-term cortical bone resorption. Here, the bone responds to the tensile stimulus of growth and acquisition due to the presence of the muscles such as the tendon of the temporalis, buccinator, and the raphe. Crest of the ridge is considered as a secondary stress-bearing area. The epithelium is keratinized and the submucosa is loosely attached to the periosteum. Musculature. The muscular forces can be used to increase the retention and the stability of the dentures. The action of the buccinator, orbicularis oris, and the intrinsic and extrinsic muscles of the tongue are the key muscles. The impression techniques, the design of the labial buccal and the lingual polished surfaces of the denture, and the forms of the dental arches must be considered when balancing the force generated by the tongue and the perioral musculature. As the form and size of the denture base supporting tissue changes, harnessing the muscular forces becomes more important in the denture retention and stability. Coming to biomechanics of the oral mucosa, a static response, it's a short-term response or an instant response to elastic more or less can vary over a broad range. Dynamic response is a long-term response which is induced by the viscosity or the permeability of the liquid component. It is a time-dependent process. Into volumetric responses to loading, it's determined by the compressibility of the Poisson's ratio. It is a tendency to resist a volumetric change when material is deformed. And the last one is the surface interactive response, friction coefficient between the mucosa and prosthesis. So material with a higher wettability will be more likely to form a superior lubricating layer between the supporting mucosa surface of the denture base. Clyde and his associates described the viscoelastic character of the denture supporting tissues. Here, the initial elastic compression of the soft tissue instantly on an application of a load. And then there's a delayed elastic compression of tissue that takes place slowly as the duration of the load is extended. When the load is removed, there is an instant elastic decompression occurs, followed by a continued elastic recovery. Loaded epithelium demonstrate decrease in the depth of the epithelial ridges and the connective tissues are obliterated. Now it takes 4 hours to recover after a moderate loading of 10 minutes. Coming to the relief effect, it was given by Hanau as a resiliency-like effect. The mucosa on which the dentures are fabricated are displaceable and compressible. The masticatory mucosa is formed and offers resistance to deformation under applied load. There is change in the kinetic energy to elastic energy and reverting back to the kinetic energy. The submucosa dampens the vibration by converting the mechanical energy into the heat. A good healthy mucosa with a distinct submucosa layer serves to support the relationship between the integral surface of the denture base and the underlying tissue surface under varying degree of denture loads and function. How to compensate for the relief effect? Preparing the mouth for the prosthesis. So we give sufficient time for recovery. We ask the patient not to wear the dentures 24 hours prior the impressions are made. Soft relining materials, they allow uniform distribution of stress at the mucosa lining interface. The impression, whether there is thin or no submucosa or non-keratinized tissue is present, it should be relieved. Impression technique with a mild displacement should be used. Jaw relation, the relief effect is also seen in the TMJ, and the mucosa. Hana said the relief effect is a chief source in registering maxillomandibular relationship, and the centric relation registration should be made under minimal or zero pressure. Clinical remounting eliminates the differences between the resiliency of the tissue and the impression cast, and so selective grinding can be done in unstrained mounting. Masticatory load. The force required varies depending on the type of the food and depending the loading of the supporting tissue. So in the natural state, the masticatory load exerted is around 200 newtons, and in the complete denture is 60 to 80 newtons. So in a dentulous patient, from the teeth, the load is passed on to a large periodontal ligament area and then onto the bone. Now this adapts to the forces, whereas in an edentulous patient, from the mucosa, it is directly onto the bone, which is not well adapted to forces. Coming to a study where comparative study of mastication between the complete denture wearers and dented patients was done. Here, the computer system was used for simultaneously collecting and processing the mandibular movements and myoelectrical activity of the masseter muscle in 15 dentate and 11 complete denture wearers. Displacement velocity, cycle of the mandibular movements, and the muscular mean potential indices were observed during mastication. A study concluded that mastication on the left and right side in the same subject was identical with respect to displacement, velocity, and the cycle, indicating that the masticative pattern is symmetric and stable. No difference between the displacement or velocity between the complete denture wearer and dentate patients show that a good complete denture may be in accord with good physiology and rest of masticatory function and health. During the mandibular opening phase, the mean myoelectrical potential of the elevator muscles of the complete denture wearer tend to increase compared with those of the dentate patients. The mean myoelectrical potential of the masseter and anterior temporal muscle on working side are greater than those on the non-working side. Coming to another study, a comparative evaluation of the maximum bite force in dentulous and edentulous individuals with different facial form. The aim was to evaluate the mean maximum bite force in dentulous and edentulous individuals with Angus class 1 occlusion and assess the difference effect of different facial forms such as square tapering and oval on the biting force. The study concluded that the square face form contributed to a high bite force value obtained higher mechanical advantage from muscles of mastication. Now, they said it could be because as the ramus becomes more vertical and gonial angle becomes acute, the elevator muscles exhibit greater mechanical advantage, because of which a square facial form individual exhibit remarkably high bite force. Coming to natural and prosthetic dental occlusion, functional and parafunctional considerations. The dentition development characterized by a period of dental, alveolar, and craniofacial adaptability, which is also when the motor skills and the neuromuscular learning is developing. In the healthy adult dentition, adaptive mechanisms are restricted to wear at region drifting of the teeth, and the protective reflexes are learned. And the dentition begins to deteriorate, the dentist uses the fixed and removable prosthodontic therapy in an attempt to make the functional occlusal equilibrium. There is diminished dental reflexes and adaptation by bone responses. Finally, in the edentulous state, only few natural adaptive mechanisms remain, and there is an increased risk of maladaptive denture wearing experience. Coming to the dentulous, the greatest force acting on the teeth are normally produced by mastication and deglutition, and are essentially vertical in nature. Teeth are in occlusion only during the functional movement of chewing, deglutition, and during the movements associated with parafunction. In the edentulous, the dentures move during mastication because of the dislodging forces of the surrounding musculature. This can be the displacing, lifting, tilting, rotating of the prosthesis. The dentures come in contact even when the patient is carrying out functional movements like during speaking, smiling, etc. Chewing is restricted to a short duration in a day, and deglutition occurs around 500 times in a day. In a day, the teeth are subjected to functional forces of 17.5 times per day. Coming to trajectories of forces, Wolff's law states that the mechanical stimulus can cause the changes in the bone structure and the surface contour. Now, applied masticatory load cannot just disappear into the maxillary and the mandibular geometry, and they are distributed to the craniofacial complex via stress trajectories. There are four stress trajectories in the mandible, and in the maxilla, there are vertical trajectories and horizontal trajectories. So in the maxilla, these follow an upward direction running from the middle third of the face to reaching the frontal bone. So in a dentate person, the periodontal ligament, it acts as a buffer space and distributes the occlusal load in the more even stress distribution within the trabecular lattices. In the denture wearing patient, the mucosa performs the load modifying and distributing function of the periodontal ligament to some extent. But so in an artificial denture, we aim to arrange the teeth in the position as that of a natural teeth. The forces are supposed to follow the same pathway. Function, mastication, and other mandibular movements. Mastication consists of a rhythmic separation of the opposing of the jaw and involves biophysical and biochemical, mechanical processes, including the use of lip, teeth, cheek, tongue, palate, and other oral structures. The neutral zone philosophy is based on the concept that each patient, there exists a specific area within the denture space where the function of the musculature will not unseat the denture. At the same time, when the forces generated by the tongue are neutralized, or the forces generated by the lip and the cheeks. Prior to a study where the effect of denture factors on masticatory performance, the location of the food platforms was done. It concluded that the position of the food platform on the crest of the lower ridge at the height of the lower canine and parallel to the flat portion of the lower ridge was found to be most effective for the subjects to chew the two test foods, and a significant reduction in the chewing efficiency of the subjects resulted when the food platform were moved in denture in a position buccal to the crest of the ridge. Parafunctional considerations, non-functional or parafunctional habits involving repeated or sustained occlusion of the teeth can be harmful to the teeth and other components of the mastication. Clenching is common in the dentate patients. The patients tend to occlude the denture more frequently at first to strengthen their confidence in retention. Such an experience is a part and process of the adaptation. Yam in 1972 suggests that the stresses can induce increase in the activity of the muscle and temporal muscles in denture, which in turn can cause tooth contact and eventually soreness in the underlying mucosa. He infers that the pressure is similar to the generalized soreness, which can be caused by an increased vertical dimension. So what can we do? Pressure caused by the tissue damage by occluding the locals can be subjected to a force time threshold. The dentist can seek to minimize the forces by maximizing the denture-based coverage area, developing an optimal occlusion, use of a resilient denture reliner, and give a period of rest, which is done by the nocturnal tissue rest. Coming to a study, analysis of the stress on the mucosa and basal bone underlying the complete denture with a different reliner material thickness, 3D finite element study. So here, the aim was to determine the optical thickness of the reliner material that provides the least amount of stress on the thin mucosa and the supporting bone in patients with a complete removable denture. Now, 6 thicknesses of reliner material were used. One was without material, one was 0.5, 1 mm, 1.5, 2, and 2.5 mm. The applied load was 60 newtons, which was perpendicular to the long axis, and the mucosal thickness considered was 1 mm, and it was measured in the anterior mandible. So the stress concentration was observed in the anterior portion of the mandible in the mucosa of the basal bone, and the model with a reliner material of 2 mm showed the lowest amount of compressive stress on the mucosa of 1 mm thickness. The tendency was maximum and minimum principal stress reduction when the thickness of the reliner material was up to 2 mm was indicated. Coming to changes in the morphological face height and in the temporomandibular joint. A premature reduction in the morphological face height can occur as a result of occlusal tooth surface loss due to abrasion of the occlusal surfaces of the teeth. This reduction tends to be even more conspicuous in an edentulous and complete denture wearing patients because the widely used acrylic artificial teeth are less wear resistant than the natural teeth, and the resorption of the teeth allows the denture to move closer to the basal bone. Morphological changes in the maxilla and mandible depend upon the balance of the osteoblastic and osteoclastic activity. The articular surfaces of the TMJ are also involved, and at these sites, the growth and remodeling are mediated through proliferative activity of the articular cartilages. Changes in the morphological facial height or the shape of the jawbone due to the tooth loss are inevitable and transfer to the TMJ. In the complete denture, the mean reduction in the height of the mandible process measured in the anterior region is 4 times greater than the corresponding maxilla. The loss of teeth can cause edentulism, and there is a reduction of the facial height and the bone, which causes an overclosure and the mandibular prognathism occurs. Therefore, there is a change in the position of the TMJ, and the contiguity of the opposing articular surface is maintained due to the growth and remodeling by the proliferative articular cartilages. Coming to changes in morphological facial height and temporomandibular joint is the occlusion. The concept of centric relation of the upper and the lower jaws have been long been a dominant factor in the prosthetic thinking of an occlusion. It is therefore regarding as a very useful reference of the starting point for establishing a jaw relationship in any prosthodontic treatment, particularly in the complete denture fabrication. It is also considered that in natural dentition, most functional tooth contacts occur in the mandible position slightly anterior to the centric relation, a position which is referred to as a centric occlusion. Now, a logical clinical protocol objective when we are fabricating a complete denture is to record the centric relation, which is not dependent on the presence of the occluding teeth, and it is then to establish a centric occlusion at this jaw relationship using the preferred vertical dimension of occlusion. So, a centric relation and centric occlusion thus being coincident. Now, the centric relation position acts as a proprioceptive center to guide the mandibular movements. Coming to changes in the TMJ, the classic envelope of motion, which is defined, the border movements of the mandible are reproducible, and it is within these that all other movements occur. It must also be recognized that before becoming edentulous, many patients already might have mutilated dentitions, which can result in a pathology or an adaptive structural alteration of the TMJ, and the changes in the TMJ may have occurred. It has also been reported that the impaired dental efficiency resulting from partial tooth loss, inappropriate prosthodontic treatment, or its absence can influence the outcome for the TMDs. A combination of adjunctive prosthodontic care, including the restoring of the vertical dimension, soft liner together with appropriate pharmacological and supportive therapy, are useful to are usually adequate to provide the patient with comfort. Tooth loss can adversely affect a person's appearance. Reproducible border movements within the confines of the envelope movement, therefore they would not reproduce effectively in an edentulous patient due to the pathology or any adaptive structural alteration which are there. Therefore, which will lead to an incorrect prosthodontic treatment leading to the degenerative changes and TMDs. So that's it. We require the combination of prosthodontic, pharmacological, and supportive therapy to treat this. Aesthetic behavior and adaptive responses. The tooth loss can adversely affect a person's appearance. It can cause deepening of the nasolabial group, loss of the labiodental angle, decrease in the horizontal labial angle, narrowing of the lip, increases in the columnar filtral angle, and the prognatic appearance. The discussions can be aided by the patients by providing the photograph, the pre-edentulous appearance, and relevant details from the photographs can be carefully analyzed and discussed with the patient. This process also can help identify whether the patient's cosmetic desires exceed the morphological or the functional reality. Behavioral and adaptive responses. The process requires an interpretation of a new sensory input for the CNS and acquisition of the additional motor skills so as to use a denture while speaking and eating. Edentulous patients expect to adapt to the dentures more or less instantly. This adaptation must take place in context with the patient's oral, systemic, and emotional and psychological states. Dentists must train themselves to reassure the patients, to perceive their wishes, and to know when and how to limit the patient's expectations. The acceptance of the complete denture is a process of habitualization and a gradual diminution of the responses to continued or repeated stimuli. The memory trace of a previous application of a prosthesis, there is a decrease in the response and the stimulus of the denture. Therefore, because of old age, there is a difficulty in storing the information of the wearing of a previous prosthesis and the memory is traced. Therefore, there is a difficulty in adjusting with dentures in old age. The insertion of a new denture introduces an altered environment for the tongue, requiring the intrinsic muscles to reorganize both its shape and learn activity patterns so as to confirm the reduced available space. The patient's perception and the responses to healthcare measures are now regarded as an integral part of the clinical decision-making paradigm. It is therefore not surprising to know that many edentulous patients may be described as unable to adapt to complete denture and are labeled as prosthetically maladaptive. In conclusion, the role of prosthodontists is to gain an understanding of the changes in the form and function of the mouth jaw brought about by the total loss of the teeth and possible social and behavioral consequences of tooth loss. We should be able to critically evaluate the influence of the complete denture on the remaining soft tissue and the underlying bony structure so that it helps in understanding the scope and limitation of the complete denture together with the biocompatibility and physical properties of the material used in their constructions. These are my references. Thank you.